Now, we're lucky to have Bill LeTourneau from the Mayo Clinic today to give us a lecture on systematic approach to refractory hypoxemia, the Mayo model. If you don't know Bill, he's a solid guy and he's an awesome dude and a very, very intelligent respiratory therapist. So we're honored to have him provide this lecture for us today. But a little bit about Bill. Bill has been a registered respiratory therapist for over 25 years and has been at the Mayo Clinic in Rochester for the last 10 years. Bill received his respiratory therapy education at St. Paul College and went on to receive his bachelor's and master's degree from Concordia University in St. Paul, Minnesota. He has served as the vice president of the Minnesota Society for Respiratory Care and the chair of the Clinicians Advisory Committee for the American Thoracic Society. Bill is currently serving on the Critical Care Assembly Planning Committee and the Learning Steering Committee for the American Thoracic Society. Bill, thank you so much for making yourself available to all of us. It is great to see you again. And ladies and gentlemen, please help me welcome Bill LeTourneau.
Thank you, David. I appreciate that introduction, and I really appreciate the invite for this. I'm working on sharing my screen right now and bringing up my presentation slideshow and minimize my views there. All right. Again, thank you, and happy Respiratory Therapy Week to everybody. It's an honor to be here, and I think everyone with me really loves what we do. Now, I don't want this presentation on refractory hypoxemia to sound too provincial or too hubris when it comes to the Mayo model. Really, I want this to be kind of a global clinical approach discussion that we're doing. We're not really doing anything revolutionary here at the Mayo Clinic. We basically follow the evidence, we attempt to follow the physiology, and we just try to remain consistent when it comes to treatment for refractory hypoxemia. When we think refractory hypoxemia, we think ARDS, but we'll get a little bit into the details of the definition and the criteria here. I have no conflicts of interest really related to this. I'm going to hide my thing here. Oops. Anyways, I have no conflicts of interest related to this. I may occasionally show some bias as to what we do or what I prefer, but really nothing to disclose. Learning objectives, we're really going to discuss a clinical approach to refractory hypoxemia management. Again, is it imperative that we really put a label on someone that's hypoxemic? I think our management is generally going to be similar for most patients. I'm going to describe how lung protective ventilation has evolved from its current state, and really we're going to examine kind of the lung protective strategies that we might see in the future here. This slide right here is basically going to set the stage for our discussion. It's a simplified sequence or outline for lung protective process. There's many layers to each of these processes, and we'll kind of get into some of the details related to that. But really, early identification, this is, do we see this patient coming down the hallway? We've got a sepsis patient coming our way, a pancreatitis, a pneumonia, influenza. During the COVID era, we saw these patients coming a mile away, but just so we know what's coming at us here. And then there's these other steps of lung protective ventilation related to tidal volume and plateau pressure and driving pressure. Alveolar stabilization are attempts to set an appropriate PEEP, and then we get into the prone position, and then really the end therapies here for some or the salvage therapies, ECMO. And I won't be talking a lot about ECMO, and I'll touch on prone position a little bit. But let's get into the protocol kind of as it stands. And I will admit, and I think people will probably recognize this as we go through this protocol, even though we updated it in 2000, and it was pre-COVID update, it needs a refresh. There are some areas on this that I'm not really that comfortable with, and we really don't subscribe to some of these philosophies, universally. But in general, the sequence and the flow of this is relatively stable. And really what I want to kind of highlight here is, again, we get that early identification, we work on lung protective ventilation, but I believe we're obligated by the current evidence to put some reference to the PEEP FiO2 table in there, and I'm gonna make a specific reference to this a little bit later. But again, I'm not really a huge subscriber to that PEEP FiO2 table. But really, what we're trying to do in those initial first few minutes after intubation of these patients that we recognize could be trouble for us, we want to attempt to oxygenate them at an appropriate SpO2 on a really appropriate FiO2. And again, driving pressure is the index that we really should be watching for, and we want to check that. We want to check that on a pretty frequent basis. Early on in our protocol, even before we adjust tidal volumes, in a sense, we're starting most of our patients right around 6 mils per kilo. But if we're getting high driving pressures, which means we probably have low compliance, and we have, we have an issue, low compliance and a high driving pressure, we're going to try some alveolar stabilization technique. And here we're really leaning towards that PV tool. And we'll get into the details of the PV tool, how we use it, how we interpret it, how it's a benefit to us. So that's really the initial part of our protocol, is recognition, lung protection, and an initial attempt to satisfy our PEEP requirements. After we go beyond that, we get into some areas where maybe the RT isn't quite as involved in this, because we really have to determine what's really the cause here. Is this some sort of sepsis process? Is this some sort of infection where we need some antibiotics? Is this a perfusion issue, or is this a fluid management issue? Those things we kind of recognize and we watch to make sure that they're actually being treated. But from a mechanical ventilation standpoint, we're really not able to do much with that other than manage the patient and really attempt to do no harm when it comes to our management of this. And it really comes down to that term refractory. If in fact we do determine we are refractory to our attempts of tidal volume, plateau pressure, driving pressure, PEEPs, then we really have to move to the prone position ventilation part of this. In the end, I'm going to be watching my time. If we have a lot of time left over, I'm going to throw in a bit about prone position. It's one of the very few positive studies that we have when it comes to treatment for lung protection. But we'll kind of get to that. I think we all got a lifetime of proning here over that COVID era. I do want to talk about that PEEP FiO2 table. It's really actually a mystery sometimes to people as to how well this PEEP FiO2 table performs. And that's kind of a misstatement in itself. And I talk about how well when I say that, I say how well it's performed in studies. And a lot of these studies were negative studies for whatever therapy we were trying to test for lung protective ventilation, where it was compared to the PEEP FiO2 table. And really what I just want to highlight is, and a lot of these recent studies use the high PEEP FiO2 table. And I don't think many practitioners will roll up on a patient and they'll see that they're on 80% and they're just going to arbitrarily put them on a PEEP of 20 or 22. I'm hoping that doesn't happen. That doesn't really subscribe to a physiological process. We don't know if they're lung recruiters or not. We don't know if they will respond to PEEP. So using the PEEP FiO2 table is really kind of a bottom feeder type of therapy, I believe. But let's talk about some of these risks. We have a couple of examples of risks to this, but when it comes to the inherent risks of PEEP, you're really talking about alveolar overdistension, some barotrauma, and I think probably the most important is that hemodynamic impairment. If in fact you are setting what you believe to be best PEEP based on your maneuver, but you have significant hemodynamic impairment, maybe you should probably throttle back on your best PEEP attempt and maybe just go down to a better PEEP where your hemodynamic impairment isn't quite so significant. Because if you don't really have perfusion, the lungs really probably aren't going to be able to do their job either. So there is these inherent risks with PEEP. Setting your PEEP with the PEEP FiO2 table probably magnifies these risks a bit. So I have a couple of examples of what I believe to be, we'll just say complicated or kind of confusing results from some recent studies when it comes to using that PEEP FiO2 table as a comparator. And the first one I'm going to talk about is that EP-VENT-2 study. That was an esophageal manometry study. Again, I'm going to say it was a negative study for esophageal manometry, but we'll return to that and discuss, was it really that negative? And basically what they did in this EP-VENT-2 study was compare a PEEP FiO2 table, and what they did with esophageal manometry, your expiratory transpulmonary pressure, they scaled expiratory transpulmonary pressure to whatever FiO2 you're on, similar to what they did with the PEEP FiO2 table. Bottom line is they were putting patients on higher PEEPs when they were on higher FiO2s just for the scaling process, when that really wasn't physiologically responsible. And we'll talk more about expiratory transpulmonary pressures and how we target them, but really you're targeting 0 for an expiratory transpulmonary pressure to limit overdistension and to limit atelect trauma. So really it was unusual that they scaled it in this way, but we'll return to this study because I have more to say about that. A second study that really kind of used that high PEEP FiO2 table or a PEEP FiO2 table in a sense was the ART study. The ART study got a lot of conversation when it came out 2017. It looked at recruitment maneuvers and setting PEEP as compared to using the PEEP FiO2 table. Again, the comparator was the PEEP FiO2 table, and they used a pressure control incremental step process to look at PEEPs and to look at compliance changes to adjust PEEP. And in the end, this is the scale that they used, the time scale in their treatment scale. Just 1 minute increments of this. But this was the scale they used on the second half of the study. On the first half of the study, they actually were applying very high pressures for as much as 2 minutes on the recruitment process, assessment process, and the recruitment process. During early on, they were actually getting some negative consequences of that, and they had to readjust that. Bottom line is, this was a negative study for recruitment maneuvers and a negative study for setting PEEP based on this incremental decremental process, but it was potentially a confusing, we'll just say, or complicated interpretation, because what the ART study really told me was, don't do recruitment maneuvers on patients who don't have recruitable lung. There was some editorials written later after this ART study saying this was the death of the open lung strategy, death of recruiting the lung and keeping it open. But actually it was just a declaration of, don't do recruitment maneuvers on patients who don't have recruitable lung. And in the end, when it comes to the PEEP FiO2 table, what the EP-VENT-2 study said and the ART study basically said is the PEEP FiO2 table in those two instances was just as good as a flawed study, potentially. So I'm not going to put a lot of stock in the PEEP FiO2 table beyond that. Okay. So there is some good news. We have some recent guidelines. Well, just kidding. We do have recent guidelines, but I don't think they really help us. The ATS and the European Society for European Society for Intensive Care Medicine put out some guidelines on the treatment for ARDS. They're actually comprehensive guidelines, and they help in a number of ways when it comes to management of the patient, but I don't think vent management of the ARDS patient really has improved based on these guidelines. And I'll just quickly go through some of these recommendations. We'll start with the ATS guideline, came out earlier this year. Excellent group of researchers and authors on this, excuse me. And they came up with a nice little scale here, basically saying strongly recommend against recruitment maneuvers, and they're specific to prolonged recruitment maneuvers and high frequency oscillatory ventilation. Okay, I can understand that. And there's some conditional recommendations for these other things that we do, and very strong recommendations for lung protective ventilation. Well, being very specific when I'm going through these guidelines, you look at PEEP and recruitment maneuvers, and basically the ATS is very soft on recruitment maneuvers, very soft on just routine use of high PEEP for ARDS. But really what it came down to, and they admitted this in the recommendation in the paper here, that none of these studies that they used as evidence to suggest strongly or for or against this, none of these studies they assessed recruitability of the lung on these patients. And that's where we're really lacking in our evidence, in our research, is we have a lot of evidence, but they put everyone in the same bucket and they pour them out. They don't really say these patients show potential for recruitability. These patients do not, and then treat them accordingly. European Society also put out their guidelines. I think it was in December of last year, so pretty close. And they were also looking at PEEP and recruitment maneuvers, and they weren't able to make a good recommendation for the routine PEEP titration in really any fashion when it comes to our ARDS patients. And they even went on to talk about lung recruitment maneuvers, and they actually recommended against lung recruitment maneuvers, prolonged recruitment maneuvers, and they went so far as to say they recommended against use of short recruitment maneuvers, which in fact we use in our PV tool. Our recruitment maneuvers are generally pretty short. The actual recruitment part is less than 10 seconds usually, but the whole maneuver may last about 30 seconds. But they're suggesting against it. Again, these recommendations are based on studies that don't include assessment for recruitability of the lung. So they're kind of handcuffed in this way. They have to make these recommendations because there aren't any studies out there that actually are positive for these maneuvers. And that's based on really the study protocol and how things were actually produced in the end. So let's get on to our process here when it comes to treatment of the refractory hypoxemia or the hypoxemic patient. Really, we haven't established that they're refractory yet. That early recognition process right now, if you remember the Berlin definition, the kind of updated definition came out in about 2012. This is kind of a mislabel here. It's really not a definition here that they're really presenting. They're just presenting criteria. The criteria to call someone ARDS essentially is just based on timing, acute onset, some imaging, lack of cardiac involvement, and some oxygenation indexes. That's really the criteria for ARDS. The definition of ARDS really involves vascular permeability, some fluid buildup, some inflammatory process. That's really the definition. But anyways, all of this kind of helps us recognize what's coming to us, what's coming our way. So let's talk about now what we think we know, and talk about what we're really going to do with these patients when it comes to lung protective ventilation. So basically, we're going to try to manage tidal volume. We're all pretty familiar with that. Took us a while to get there, but we're there now. We're going to attempt to manage plateau pressures, again, when it's appropriate, attempt to identify an appropriate PEEP. And I try to stay away from the terms optimal PEEP or best PEEP, because sometimes trying to find that is really going to lead you down the wrong path. And then all the while, we're hoping to decrease driving pressure. Driving pressure hasn't been studied in a randomized clinical trial, but the evidence for driving pressure is pretty strong. So let's talk about tidal volume. This is usually our starting point when we're setting up the ventilator. We're setting a tidal volume. Normal tidal volume or physiologic tidal volume, 6 to 8 mils per kilo. Ultra protective tidal volume, 4 to 6. I won't publicly recommend anybody set anybody at over 8 mils per kilo, but I'm sure there are some instances where that could be beneficial. I do kind of caution against the ultra protective lung ventilation. If you're going to be going down to 4 and 5 mils per kilo, there are some clinical consequences to that when it comes to synchrony, when it comes to dead space ventilation. But those are going to be case by case basis, and we're going to have to recognize them. So there is a question then: is the tidal volume in mils per kilo the same for everyone, and is 8 mils unsafe? Well, I'll save that second answer, 8 mils unsafe, for your clinical judgment on a case-by-case basis. But I will answer that first one: is tidal volume the same for everyone? I think we've established that it's not. Just because you choose 6 mils per kilo doesn't mean it's going to be absolutely safe for that patient. We have to remember the whole Gattinoni's concept of the baby lung that he published a few decades ago. Really what it comes down to is just because you're at a certain height and a certain gender doesn't mean all of that lung is going to be available for ventilation. You're going to have some consolidation. You're going to have some socked in areas of the lung that just are not going to accept ventilation. And we have to attempt to determine what is really the aerated amount of the lung and what can we ventilate. And that may be less than 6 mils per kilo. So there's very few positive studies about lung protective ventilation, like I mentioned, but this is one of them. And when it comes to tidal volume, this is the seminal study that said, hey, let's manage our tidal volumes. This is the ARMA trial of the ARDSNet network that said, hey, let's attempt to go with tidal volumes of 6 versus 12, essentially is what they tested against or in the trial. So the group receiving lower tidal volumes of 6 mils per kilo versus the group receiving higher tidal volumes of 12 mils per kilo, there was clearly a statistically significant difference in mortality. It looks good. I like, 31% mortality on these ARDS patients is not bad. And even in this group, 40% back, 25 years ago, 40% mortality wasn't that awful either, but clearly a benefit with a lower tidal volume. They also recognized a benefit of managing plateau pressures. If your plateau pressures were over 30, you're going to have poorer outcomes when it comes to survival. And a very interesting secondary piece of data here is if you're just looking at oxygenation as an index for survival, you're probably not going to meet your survival outcome goals. And our PF ratios, our groups with the 12 mils per kilo in the first few days had a much higher PF ratio, but they had a poorer survival rate. So just looking at oxygenation is not a good index for determination of survival. There are actually a couple of examples of early indicators of what we should do. In this particular study by Amato from 1998, and I'm sure the data was probably from the mid 90s, so close to 30 years old, basically said, lung protective ventilation will actually give you better survival. And they're looking at tidal volumes, and you can see it was much more protective and statistically significant in its survival difference if we're using lung protective ventilation. Again, I want to say the data for this was mid 90s. The ARMA trial came out in 2000, but even after 2000, it probably took us a decade to universally accept and universally set our patients to a lung protective tidal volume of under 8 mils per kilo. The literature really kind of teases that out, that we still weren't being that lung protective, even up till about 2010. Another early study, and this is back in 1975, where this group basically said, hey, go ahead and attempt to set your PEEP by using best compliance. And by increasing your PEEP, we're actually showing an improved compliance. We're showing decreased dead space, increased O2 consumption until we hit basically a threshold where some of that benefit started to decline. But again, you'll notice the PaO2 just kept rising and rising. So if you were targeting PaO2 for your patient benefit, you're not going to get the best benefit with the highest PaO2. Basically, what we're saying here is follow the physiology, follow your lung mechanics. There's still a lot of discussion about should we be setting PEEP just solely based on compliance, and I don't think that's our sole component. And we'll talk about driving pressure in a little bit here and discuss how compliance really plays into that driving pressure. All right, we talked about tidal volume. Let's talk about plateau pressure, because that was part of the ARMA results as well. And plateau pressure, you should be measuring plateau on everybody, and even every mode. You essentially, if you get your static conditions right, you can get a plateau pressure on just about any patient with the right conditions. But our sickest patients, we should be measuring plateau pressure on everybody. You can't really get a calculated driving pressure if you don't have that. But bottom line is, plateau pressures have significance, potential barotrauma, have some advantages. It's very easily measured, and there's good data to say it has some value. And again, a driving pressure is part of that. But there are limitations as well. It does not consider chest wall contribution. The plateau pressure that we see and the compliance we see on our ventilators is basically just based on respiratory system compliance, not chest wall compliance. And our obese patients or some of our increased abdominal pressure patients, They may have increased plateau pressures, but it's all because of a chest wall compliance issue, not a lung compliance issue. And there may be some mismeasurement during this. There may be some active patient contribution that changes our compliance, that may change some of our readings that our ventilator is going to display. So we have to be careful of that. So we've talked about tidal volume, and we've talked about plateau pressure a little bit. And before we get to PEEP, I kind of want to address a question of volume and pressures as basically the culprit of lung injury. This is one of my older slides. It's kind of a stale slide, but I still like going back to it since it really has a good message in the end. And this was, oh man, what was this? Almost 50 years ago here. Dreyfus and his group basically were saying, what's causing lung injury, pressure or volume? And they were really looking kind of at involvement of PEEP as well. So I'm simplifying their conclusion to this. But basically what we're looking at here is they took a bunch of rodents here and they applied different conditions to them. Normal pressure, normal volume, obviously didn't include any pulmonary edema or inflict any alveolar flooding. So these little rodents were able to go on and lead some productive lives. They added high pressure, high volume to these rodents, and we're talking 50 mils per kilo for tidal volume on these, probably vaporizing some of these little rodents. But again, significant lung injury, pulmonary edema, alveolar flooding. I don't think many of the rats survived this category. And then they went with high pressure, low volume. What they did is they just put a little strap around the chest, which again kind of mimics obesity or mimics high abdominal distending pressures, which again just decreases chest wall compliance, but it doesn't do much for lung compliance or harm lung compliance. Basically, in these patients with the straps around their chest, no injury, no pulmonary edema, no alveolar flooding. They created a little iron lung for these rodents and generated some negative pressure. So low pressures, subatmospheric, which were generating high tidal volumes, generating pulmonary edema and alveolar flooding. So if we just look at this graph on its face value, we've got high volume and high volume are the ones generating injury, independent of pressure, essentially. That's what it says on the face, but you have to really kind of look at it underneath. I interpret this as these two categories are generating high transpulmonary pressures, which is actually the cause of lung injury. Yeah, volume is a culprit, but pressure is a culprit as well. So we have to be careful of those kind of these interpretations. All right, let's talk about PEEP. Some really good systematic reviews have come out about PEEP, higher PEEP versus lower PEEP strategies in ARDS. Very knowledgeable group here that produced this meta-analysis for the Annals of ATS. And basically, they came to the conclusion that the use of higher PEEP is unlikely to improve clinical outcomes among unselected patients with ARDS. The key here is this word unselected. And again, I think they even admit during this meta-analysis paper that very few, if any, of these patients in these studies were assessed for lung recruitability. So again, we can't really say higher PEEP is it's better or worse for patients if we don't know if they'll benefit from higher PEEP. But the meta-analysis doesn't lie. You know, all of your whiskers here are coming across this no favor outline here. So basically, they have to say that based on the data that we have, that higher PEEP isn't good. But you have to remember, for unselected patients. There was a study done here by Gattinoni and his group that attempted to look at some recruitability component to selection of PEEP. And they looked at 4 different processes: an express process that used compliance to set PEEP, stress index, which used a pressure time profile, esophageal manometry, and there's that PEEP FiO2 table again. Looked at those 4 alveolar stabilization techniques and really kind of taking into account lung recruitability. And when looking at these patients, the mild ARDS patients showed the least lung recruitability, especially compared to severe ARDS. So they found that baseline. And then when they did all these techniques, this LOV, this is our PEEP FiO2 table, was the one that actually demonstrated probably the most appropriate PEEP setting when it came to the non-recruitable lung. Very interesting study, excellent investigators and authors, but I still have some concerns about this because when they included the data of the end expiratory transpulmonary pressure on all of these patients, it was very positive. And again, we want our end expiratory transpulmonary pressure to be 0. We would like it to be limit over distension, limit atelectrauma, and all of these end expiratory transpulmonary pressures were, in some of these were in double digits. So it confused me a little bit as to how much I should really consider the results of this study and how it was conducted. Again, recruitment of the lung is important here. So let's talk about these alveolar stabilization techniques. What we use here on a pretty regular basis is a PV tool, and we use esophageal manometry as well. Some pretty reliable tools. It takes a little bit of a learning curve to understand, the values that you're getting and make some interpretations of them. But by using some of these is probably some of the best information that the RT can bring from the bedside to the team to make some recommendations. And I'll talk a little bit of detail here as to what we're doing with the PV tool. There's a few different generations of software. I'm going to show you the screen profile of their newest generation of software where you can actually separate out a assessment process. And if they look like they have recruitable lung during the assessment process, we can go to a recruitment maneuver tool as well. So basically, in these cases, the new software, the way I understand it, will bring what we call the hysteresis value to its largest value after the maneuver is done. We're still moving our cursor and looking at our hysteresis at a pressure of 20, trying to keep it consistent for most patients. The previous data showed looking at all patients at a pressure of 20 really limits the overestimation or underestimation of recruitability. So we're still using that model. But like I said, the new software actually brings this hysteresis number to its largest point. And this hysteresis number is displayed right here in this volume difference. That tells you your volume of hysteresis. And then what we do with that volume is we divide it by the total inflation volume right there. And we're looking for a percentage. And it's a normalized maximal distance percentage. And the evidence says, greater than 40 or basically 41% shows a very strong signal for recruitability. I live, in the world where if they're in the 30 percentiles, that shows some recruitability, high 20 percentiles, a little bit of lung recruitment. But if they're in the teens and the low 20s, and that will really show a limited hysteresis in this profile as well, that shows, very limited or a non-recruitable lung. So by doing this simple assessment maneuver, it'll give me a lower inflection point, or I can, believe it or not, find some starting point of where to set my PEEP, and I'll generally set it about 2 centimeters of water pressure above my lower inflection point, just to get it up on that linear part of the curve. And then I'll do an assessment of, do they have recruitable lung? So with this simple assessment tool, I can target a PEEP, and then I can determine, should I actually do a recruitment maneuver on this patient or not? And then when you do the recruitment maneuver, for however you want, this particular one, we paused at a pressure of 40 for 8 seconds. And then after the maneuver is done, it'll actually show you what your recruited volume was at the end of that recruitment maneuver. And you're really targeting about 2 mils per kilo. So about 150 for most adults is pretty good recruitment. I mean, if you only get 100, you only get 100. Or if you get 250, that's what you recruited. But it's a relatively simple assessment tool and a simple process that we can do. And we'll do these generally right after intubation. They're still pretty heavily sedated and possibly still paralyzed from the intubation. So there's no patient interruption in this. And that's our initial assessment of alveolar stabilization. And we've been relatively successful with this. I'm not going to tell you that this process nails the PEEP every time. Because that's a dynamic process as well. Just because it told me my PEEP should be 12 doesn't mean I need to stay there. And here's and I talked about this, doing in-services and visiting with people about this normalized maximal distance, and that percentage of greater than 40% shows a strong signal for recruitable lung. This is one of the papers that really demonstrated that. They talk about this normalized maximal distance here, and it fell right in here at about 40 or 41%. That's really a strong signal for recruitable lung. And I cannot emphasize this enough. If you don't really assess for recruitable lung, you're really going to struggle with the physiology of this, struggle with adverse effects of PEEP if you're really going to continue to raise PEEP on patients who don't have recruitable lung. Some of the recent papers are actually suggesting this process. This is paper from Critical Care Explorations in 2021. They really added this into their flowchart of assess for potential for lung recruitment. And then it actually sends you in some other directions like higher PEEP versus lower PEEP. It doesn't mean that clinically, and I'll talk clinical reality here for a second, if you do this assessment and it demonstrates that you have a non-recruitable lung, the care team may still want to put them on PEEPs of 10 or 12. And that's the conversation you're going to have to have at the bedside and really demonstrate to them, maybe this is their driving pressure at a PEEP of 7, and this is their driving pressure at a PEEP of 12. And then the whole team can come together for a good discussion and then an informed and intelligent decision on what PEEP you want to apply. We also use esophageal manometry, and esophageal manometry is that surrogate for transpulmonary pressure. And again, the formula for transpulmonary pressure is not that complicated. It's just airway pressure minus your pleural pressure, and we use esophageal pressure as that surrogate for pleural pressure. And here's, lung stress. If you're familiar with those terms, lung stress and lung strain, this is your lung stress. It's your inspiratory transpulmonary pressure. Here is your expiratory transpulmonary pressure again. That's your PEEP that you have set minus your esophageal pressure, and you really want that to be 0, or some people will go so high as a -3 to a +3 for their threshold range, and that's fine, but I just want to target 0 at least, okay? The big studies for esophageal manometry were our EP-VENT study and our EP-VENT 2 study. The EP-VENT study came out in 2008. And again, looking at esophageal manometry to the PEEP FiO2 table, and I already kind of mentioned that we were scaling expiratory transpulmonary pressure. And that original EP-VENT study in 2008, it was a small study, 30 patients in each arm, single center study. So I'm pretty confident they were very diligent about managing their FiO2s, and I doubt many of their patients had greater than 60% or 50% FiO2s. So rarely did they have to apply, more than a +2 on their expiratory transpulmonary pressure. So they really weren't over distending. And the results of that study were very good when it came to compliance and dead space ratio. So it's a positive study, significantly improves some of these things that we're looking for. They needed a randomized control trial to really kind of validate this. So this was our EP-VENT 2 study that they did. Multiple centers, again, they scaled the esophageal expiratory, they scaled their expiratory transpulmonary pressures. And since it was a randomized controlled trial, many centers, you could probably guess they weren't as diligent keeping their FiO2s down. So they probably had a few patients that were on these +4, +5, +6 when it came to expiratory transpulmonary pressures, which actually led to a negative study for expiratory transpulmonary pressures. The mortality was not statistically significant when it came to a difference. So basically, it said the PEEP FiO2 table was as good as esophageal manometry. And I will just say, again, this is a bias and this is an opinion. You're basically saying the PEEP FiO2 table is as good as using esophageal manometry the wrong way. They eventually, and here's some of the demonstration is, the authors corrected for this very well and explained this very well on all of these outliers when it came to plateau pressures and PEEP, but in the end, it was a negative study. But during COVID, and it basically said these findings do not support the use of esophageal manometry in PEEP titration of ARDS. Very skeptical of that at the time, but these authors did have some time during COVID to reflect on this paper and take a look at it, and basically they did a reanalysis of the data and basically said, if we actually target our expiratory transpulmonary pressures closer to 0 centimeters of water pressure, closer to balance, we're going to have a survival benefit by titrating PEEP with esophageal manometry. This has not been vetted in a clinical trial yet, so they can't use this information when recommending things in clinical practice guidelines. But to me, the evidence is there. Esophageal manometry still has some utility. Again, basically, you're just looking for balance here. You don't want atelectasis. You don't want overdistension. You just want some sort of balance within the alveolar environment. There's a couple of papers out there that have suggested that the use of esophageal manometry is relatively accurate in a lot of regions of the lung. And it's also relatively accurate if we have asymmetrical lung injuries. If we have large pleural effusions on one side, we're still going to have some relatively accurate numbers, at least numbers good enough where you can do some management of these patients with esophageal manometry. All right, let's move on to driving pressure now. We've talked about tidal volumes and plateau pressures and PEEP. Let's talk about driving pressure and how we're gonna manage that. We at the bedside calculate driving pressure by plateau minus PEEP. Here's where compliance comes into the picture once again. The actual formula for calculating driving pressure is tidal volume divided by respiratory system compliance. And if you remember the formula for respiratory system compliance, it's tidal volume divided by plateau minus PEEP. So if you divide tidal volume by respiratory system compliance, your two tidal volumes are eliminated and you're left with plateau minus PEEP. That's where we come up with this formula. But really what we're suggesting with driving pressure is the lung's ability to accept a tidal volume. And that's kind of a surrogate definition for compliance. So when we're talking driving pressure, we're still talking about compliance. Amato produced this paper, it was back in 2015, really kind of changed our thoughts about the index we're going to use for these patients. And we started using driving pressures, and they suggested keeping your driving pressures less than 15. I think that number has subsequently moved down the scale a little bit, closer to 13. But again, they don't know what a dangerous driving pressure is. And again, I'll repeat, this has not been tested in a randomized clinical trial. It's currently being done, so it hasn't been validated in a sense where we can really use it in some sort of clinical practice guidelines. The evidence is there for me. Driving pressure is the index that we really should be following. All right. When it comes to driving pressure, whatever you're doing with your knob turning, changing your PEEPs, trying to manage your tidal volumes and your plateau pressures, if whatever you're doing with that increases your driving pressure, well, your mortality is going to increase. If what you're doing with all your manipulations with PEEP and tidal volume really just keep your driving pressures the same, well, your mortality is going to be the same. You won't have a benefit. The good news is your patients won't be dying at a higher rate, but there's not a real benefit. But in the end, and I even tell the nurses this when I discuss mechanical ventilation with them, the respiratory therapists and the physicians all day, they're coming in and they're turning knobs and they're manipulating the ventilator. If what they've done over the course of that day has decreased driving pressure, well, then your patient has a better chance to survive. Really, in the end, that's what driving pressure is telling us. And that's what Amato told us. They didn't do a trial on this, but the data demonstrated that. It's not all that difficult, though. You don't need special tools. Basically, let's just look at this particular patient. They're on a PEEP of 8. They have a pretty low compliance there, and they have a pretty high driving pressure. A simple maneuver is to turn their PEEP up to 12, take a look at their compliance, and take a look at their driving pressure. If you see an improvement in compliance, which at the same tidal volume is going to bring your driving pressure down, the only real explanation for that is there's some lung tissue that's being recruited. So just a small change, well, it's not really a small, going from 8 to 12 isn't, I won't say small, but just a change in that without any special tools, without esophageal manometry, without a PV tool, you can come to some conclusion that they have recruitable lung and you're going to have a benefit from turning your PEEP up. That's not to say that maybe you went from 8 to 12 and you didn't see any change yet. You may not have reached that threshold yet where it opens up alveolar tissue. So You may still have to go higher, but transiently making these adjustments and making these assessments probably isn't going to do any harm to your patient. So, I would encourage you doing these assessments. All right. And basically, driving pressure is lung strain. I said lung stress is inspiratory transpulmonary pressure. If you want to talk about lung strain, well, driving pressure is really that. Lung strain is tidal volume divided by FRC, but we really don't measure FRC, but it's tidal volume divided by lungs' ability to accept a volume. And that really falls into the driving pressure definition. All right. So what are we going to do next? Okay. What's on the horizon here? And there's a few things that we can discuss, and I'll briefly discuss these because I do want to leave time for some questions here. We still want to manage, we want to consider hemodynamics when it comes to these patients. We want to make sure where we're setting our PEEP really has the least amount effect on the RV, least amount of effect on pulmonary vascular resistance. This little graph here doesn't tell you where to set PEEP. It's just a demonstration of really look at some of these extra things when it comes to hemodynamics to adjust your PEEP. Like I said before, following oxygenation isn't a great index for lung protective ventilation. There's a number of studies out there that actually show what potentially could be your oxygen saturation targets, but I think 88 to 93 is a good target. We do know oximetry is not accurate on everybody, so really take that into clinical consideration and really go back to the basics as well, knowing your oxyhemoglobin dissociation curve and knowing those shifts to the right, you're probably going to have a higher PaO2 on the same saturation. So maybe your saturations are only 87 or 88, but that's probably going to produce a higher PaO2 on those shifts to the right because the body is really going to be pulling more oxygen from the hemoglobin. Something else that I'm extremely interested in and very curious about is this biologically variable ventilation. And this particular paper here really just suggests something related to size and what potentially could be going on with surfactant activity and inactivity when you have this very homogeneous delivery of tidal volumes. It essentially turns the puts the surfactant to sleep. Add some biological variability, and your surfactant may actually be a little more active. Nothing is clinically proven on this, but it has a physiological basis that's very interesting. This is one that's kind of out there, but I came across this and it's very interesting, talking about negative pressure ventilation versus positive pressure ventilation. And the negative pressure ventilation really induces much less local tissue strain on the lung. I'm not suggesting we put anybody in an iron lung who's an ARDS right now, but it's an interesting concept and some interesting physiology. Dr. Marini and his group actually put out an interesting paper here about lung compliance and driving pressures, and what we're actually seeing on the ventilator may not actually be that accurate as to what's happening in the lungs, and it's something we probably need to investigate a little further, and is the accuracy of our ventilators. This paradoxical thing that came up during COVID was also very interesting, where we kind of believe that by sitting our patients up, we actually improve lung compliance. But on some of our COVID patients, we were laying them down, and we were actually improving lung compliance just based on some of that abdominal tension movement that actually, if we sat them up, that was actually pulling on the lungs a little bit more and making them more, the compliance less. And then when we laid them down, it relaxed that tension and made the compliance a little better. So again, this is very anecdotal, but it's something to consider on an individual basis when you're really struggling to find that best position of the patient. Let's see how I'm doing for time here. Electrical impedance tomography, you could talk for an hour on this. Really, it's just what is electrical impedance tomography and how should we use it? We really have to decide, is this belt placement accurate? Is the data accurate? Is the interpretation universal among providers? And then what are we going to use it for? Are we going to use it for ventilation, or are we going to use it for some sort of pulmonary vascular related issues? That's more to come on that. The only thing I really wanted to talk about with prone position was it was one of the other studies that it was a positive study for a therapy. Prone position had excellent mortality benefit, only 16% mortality compared to 33% mortality in this ProSiva study. Really, if you're going to go by the numbers for prone position, your PF ratio is probably going to be less than 150, I should say. You're going to have some poor lung mechanics. Prone them for at least 16 hours. Basically, I heard a physician recently say, if your patient doesn't die by proning them, leave them proned, because you're going to have some baseline respiratory mechanics and hemodynamics potentially that may worsen initially. But if they do, if the mechanics worsen a little bit, just try to keep them prone and see if you get the benefit from it. So to wrap it up here, and then we can maybe answer a few questions. We're close to being truly lung protective. We're not quite there. We do need some good studies that don't use unnecessarily aggressive procedures and that are well protocolized. So attempt to remain within the current lung protective approach. And if you leave here with one message from me, assess, do they have recruitable lung or not? Because if they have recruitable lung, they're probably going to benefit from an increase in PEEP. I'm not going to say that's absolute. But if they don't have recruitable lung, there's probably a higher chance that hemodynamically they're going to suffer by you increasing the PEEP, which again is definitely going to influence your outcomes. So I packed a lot in here in about 25 minutes, trying to allow for a few questions. I wanted to keep this within an hour. So I think I'm going to stop sharing there, and I'll let David join me, and we'll see if we have any questions. I'm sure if nobody submitted questions, I'm sure David has a ton of very relevant and intelligent questions.
Hey, Bill, this isn't our first rodeo, so even if there's minimal questions, of course I got some. But Bill, first off, once again, fantastic job. Delivered as planned. Great review of everything that's related to managing acute lung injury and ventilator-induced lung injury. So more of a statement that came through the Q&A session, and it's more of a two-part statement, but curious at your opinion on it. Why do we not consider, or why can't we use the SF ratio to improve oxygenation? What are your thoughts on the use of the SF ratio versus PF ratio?
Well, I think the SF ratio has got a lot of attention lately, and it's been fleshed out as relatively accurate. And in some of the newer definitions of ARDS that were put out, they're allowing the use of that for meeting criteria for ARDS in low resource areas that don't have the ability to produce blood gases. Again, well, I'm sure there's other limitations, but the biggest limitation that I come across with saturations is the accuracy of it. There's a number of things that can affect the accuracy, skin pigmentation being the one that's being highlighted the most. But yeah, if that's what you have, go ahead and use it. In the end, and it's really important, I think, to remember, it doesn't matter how you categorize these patients or what you call them. You can call them ARDS, you can call them hypoxemia. You need to follow the physiology. You need to follow the how they respond to what you're doing. And if they're responding well to what you're doing, continue to do it, try to optimize it. If not, then you're gonna have to go another direction. It doesn't matter if you call them ARDS or call them hypoxemic or not. You have to treat the physiology.
Absolutely. This in the second part of the question or statement, and again, we've all dealt with this. We all struggle with this as end users. What's your opinion on why we still struggle to desire higher PaO2s and not allow patients simply just above 60 and 70s? We all work with end users that still want those PaO2s up higher than we think they should be. So what's your opinion on that?
A good example of that is nitric oxide, I think. People love to introduce that early, and I don't have a strong opinion either way of when you introduce it. But if you have a hypoxemic patient and you don't really investigate some of the physiology, but you say, hey, I know a pulmonary vasodilator is going to give them a higher PaO2, you introduce some some nebulized pulmonary vasodilator or nitric oxide, and you see an increase in saturations, you see a increase in PaO2, and everybody's slapping themselves on the back in the patient's room. It's like, we did our job today, we improved this patient, when in fact you didn't treat the underlying issue, you didn't treat the lung mechanics, you didn't treat the problem. So that's and the studies have shown, like I showed studies from 50 years ago that said, go ahead and keep improving your PaO2, but that's not going to give you a survival benefit indicator.
And Bill, it's more my question. Just again, we've got RRT in our DNA. That's never gonna die. There's been lots of positive publications and suggestions that the way to adequately manage a diseased lung is one of the first steps is you have to adequately open the lung. You know, the lung was born and genetically constructed to be in an open position at all times. Why do you think there's still a hesitancy for us to adopt recruitment maneuvers as something to aid in getting the lung open before we manage PEEP?
All right, well, I'll give you my opinion, and maybe you want to delete this from the recording or not, but the the studies have been flawed, and I'm not saying the investigators or the authors are flawed or incompetent. These investigators and these authors are some of the best in the world, but I think they're handcuffed sometimes in the protocols that they have to produce to get these studies off the ground and get them done. And they just haven't included that assessment of lung recruitability, which has then produced negative studies for whatever therapeutic process they're trying to investigate through no fault of their own, because the protocol didn't allow for them to really truly investigate the therapy, like lung recruitment maneuvers. I'm still a fan of incremental and decremental pressure control recruitment maneuvers, but the ART study, put a dagger through the heart in that whole procedure, and it wasn't the maneuver that was the problem; it was the protocol.
Well, Bill, we're closing in on the time frame. Look, I don't know if you paid attention to it, but you've had 240 plus people listening to you today. And I think that is an amazing turnout. And for every one of you that have attended today, I hope you got something very special from Bill LeTourneau's message today.